A very warm welcome to all of you who have attended. So over the next 30 to 40 minutes or so I'll be going through with you all what an IVF journey entails, go through the factors we consider at consultation, including how to make a diagnosis, go through different treatment options and how care is individualized, as well as go through some of the additional add-ons we can consider. And afterwards, there'll be an opportunity to go through some of the questions that you have asked. So here at Care Fertility, we have a total of 26 clinics, which is spanned across the UK and Ireland, the United States and Spain. You can see that the purple dots represents our full service clinics, and the green dots represents our satellites clinics. So for example, where I'm currently based at and where I'm talking to you from is Care Tunbridge, Wales. And our nearest satellite clinic is Sittingbourne. So if patients were to have certain monitoring tests and investigations, they can have it at our Sittingbourne clinic if it's more convenient for them, and they can proceed with the main procedures such as the egg collections and the embryo transfers here at Care Tunbridge Wells. So it provides patients that little bit extra flexibility and patient choice. At initial consultation, we establish the right diagnosis, and broadly speaking, this can be divided into several categories. So it can be female factors, there can be male factors, can be a combination of both female and male factors, or it can be unexplained. And it can further be categorized into different factors. So for example, if it's with the female factors, is it ovarian in nature? So for example, is it related to polycystic ovaries? Or if it's a tubal factor? And in the male factors, is it to do with, is an issue with the sperm count or with the sperm quality? And so in order to assess this, we can perform important preliminary tests and investigations, which are summarized in this slide. And if you're using your own eggs, we can perform an AMH blood test. So AMH is a hormone, it's an important hormone, it stands for anti-Müllerian hormone, which is produced by the follicles. So the follicles are these fluid-filled sacs which contain the eggs. And the more follicles you have, the more AMH is produced. And AMH therefore tells us and is an indicator of what your egg reserve is, what your ovarian reserve is. So it tells us the quantity. And using conjunction, we can perform, when we do perform, a pelvic ultrasound scan. And we can, in particular, count the number of these follicles in that cycle on the left ovary and the right ovary and come up with a total antral follicle count. So this will help guide the treatment, the dosage, and even manage expectations. In addition to the pelvic ultrasound scan, we assess other parameters. So we have a look at the endometrial thickness. We know that through the studies, the thicker the lining is, the more chance of success. And so we make this assessment, but we also have a look to see if there's any other pathology, such as ovarian cysts, any fibroids or polyps or whatnot. And if it's relevant, we can perform a semen analysis. So there are different parameters which we look at. So we look at the sperm volume, we look at the sperm count, we look at the concentration, we look at the sperm morphology, which is essentially the percentage of normal forms, and we can look at the movement, the motility. So essentially the good swimmers, so the Adam Peaties or the Léon Marchand of, if you like. Then actually we have a video, and Sam, if you could kindly bring up the semen analysis video. So here we have a semen analysis, which the embryologist will have a look at. So you can see on the left the video, which essentially looking at the concentration. So concentration is how much sperm do we see per mil. And you can see as it works out, that was 24.7 million sperm per mil, which is a good number. And the video on the right looks at the motility. So essentially we're looking at the projection, the trajectory of the sperm. So we could calculate very cleverly the progressive motility, and in this case it's 85%, which is very good. Those which is non-progressive, 9%, and give a total motility, and in this case it's 94%. And the other parameter which we look for, like I mentioned, morphology, the percentage of the normal forms. So the embryologist and the computer will go through looking at analyzing the head, the neck, and the tail of the sperm. Anything above 4% is good. So in this particular case is actually a nice normal semen analysis. Thank you, Sam. So once you've had these preliminary tests and investigations, we go through the results with you at our initial consultation and what the results mean. We do have a cutoff BMI of 35, and the reason being is that a BMI less than 35 is associated with more positive outcomes. And also, if you are undergoing an egg collection procedure, the anesthetic risks do increase if the BMI is above 35. So we do need to take into consideration the patient's safety here as well. But if your BMI is above 35, then there are ways that we can help you to reduce that in the form of diet and exercise, in conjunction with Weight Watchers type programs, and collaboration with primary care team, including the GPs. And essentially, we come up with different targets and set realistic goals so that they're achievable. Now, in terms of the IVF process, I'll be referencing this diagram throughout the presentation. It essentially highlights the different stages of the IVF process. And essentially, there are 3 stages in total. So the first stage is concentrating on how to retrieve the egg and the sperm. So with regards to egg collection, this is initially performed through stimulating the ovaries and monitoring through ultrasound scan. And in terms of the ovarian stimulation, so on day 2 of the cycle, you're given you take an injection, which you administer yourself under the skin every day for approximately 10 days. And that helps to grow the follicles. And you can see we've got dedicated nurses who will go through with you in terms of how to administer the injections. We have also very good tutorials, video tutorials, to go through that with you as well. So you don't need to physically come in clinic to have this done. As we've stimulated the follicles, we monitor this through internal ultrasound scan, exactly as the preliminary baseline scan that you've had. And essentially, we check the growth and development of the follicles throughout the cycle, and we plot it on the graph. And we have a look at the trend, and we adjust the medication accordingly. But usually by day 10 of your cycle, you'll be ready to have the egg collection procedure. Now, the egg collection procedure essentially is very similar to the internal scan that you would have had, but this time it has a needle attached to it. So essentially, all the follicles that we've helped to grow and develop, we drain it with a fine needle. We essentially collect the fluids and give it to our embryology colleagues who are literally sitting behind us. They have a look under the microscope and they count the number of eggs. So that by the time we finish the procedure, which will take roughly 15 to 20 minutes, we're able to tell you how many eggs have been retrieved. Now, because the needle is involved, we do give sedation to keep you nice and relaxed and as comfortable as possible. When it comes to collecting the sperm, it's quite simple, really. The partner would provide an ejaculate, and you can see here these are different slides which just represents the sperm under a microscope. Or if using donor sperm, then essentially we just thaw the donor sperm at the same time at egg collection, and we see how many of the sperm will fertilize the egg. And that's where the next stage comes in. So that's where we want to fertilize the egg and the sperm and hopefully create embryos. So you can see our embryologists hard at work here. The middle picture is something what we call ICSI, or ICSI, which is an acronym which stands for sperm injection. So if one or more of the parameters, like I mentioned earlier, is on the lower side, for example, the movement or the morphology, together with the history, then we would consider ICSI. So this is where the embryologist will choose a healthy individual sperm and inject it directly into the egg to help improve that fertilization rate. And we actually have a video of this in action. And you can see here, so you can see the egg on the left, which is 10,000 times the size of the sperm. And so the embryologist is essentially piercing the egg. You can see the sperm, which has actually gone in the opposite direction. That's because of the negative pressure. But very carefully, the embryologist, you can see the sperm now, who's just injecting the sperm into the egg. So that's an option that we can consider. So once we've hopefully got fertilization, then the next step, of course, is to develop the embryos. Now, you can see in the middle slide, essentially the cells will divide. They double each time. So it goes, you can see on the top left, 1 cell, then it goes to 2 cells, goes to 4, 8, 16, etc. And you can see in the bottom right, that's a day 5 embryo. And you can see it's actually hatching. So the cells have fully expanded. They're literally are coming out of its shell. And here at Care, yes, we do offer what we call extended blastocyst culture. So essentially the embryos are placed in special culture medium to enable the more favorable environments to reach to this blastocyst stage. I mentioned earlier at the beginning, there are several add-ons, and here there are 2 important add-ons that we can also consider. So the first one is Care Maps. So Care Maps is a very innovative technique, which is a multi-award winning, technique that essentially assesses the potential of the embryo. So we have a picture of this in a video of this, sorry, in action, and you can see here. So essentially, it uses time-lapse technology. So it takes a picture every 6 seconds. This is fast forwarded, but it takes a picture every 6 seconds, and it's used with we've analyzed over nearly 500 million images with over 60,000 embryos that we know the outcomes and what the results were. So essentially, it looks at the way the cells divide. So it looks at what we call the morphokinetics, how the cells divide. And you can see here, the cells are nicely dividing. We've taken time-lapse images. And so, for example, if we develop 2 embryos, which are look similar in appearance, we can, performing Care Maps can give a scoring system. So with a Care Map score of 9 out of 10, for example, versus one which is 7 out of 10, we would transfer the one which has 9 out of 10 because that is more likely to develop into more successful outcomes. Thank you, Sam. Another add-on is PGTA. So PGTA is an acronym. It stands for Pre-Implantation Genetic Testing for Aneuploidy. Now, that's a fancy way in saying that essentially we can check the genetics of an embryo at a molecular level. And essentially, we just biopsy a couple of cells from the embryo. And we have a video of this in action as well. And if you kindly bring it up, thank you, Sam. So here the embryologist is picking a few cells from the embryo. And essentially, we send that to a lab to analyze it. And we get one of 3 results. It will tell us if the cells are normal, if it's abnormal, or if it's a mixture of normal and abnormal cells. We know that if it's an abnormal number of cells, in terms of the genetic number, then unfortunately it will not implant, or if it does, it will sadly result in a miscarriage. So we don't store those ones. We only store the ones which are normal. If it's a little bit mixture of both normal and abnormal, it can get a little complex, so we do get a genetic counselor involved. Thank you, Sam. So PGTA can be used for anyone really, but usually above 38 years of age, because that's where the number of what we call aneuploidy, the abnormal number of cells, does increase. So it's useful in that sense. So once we've created the embryos, depending on the clinical situation, it will either be a fresh embryo transfer, which is 4 or 5 days after the egg collection, or if it's frozen, it can be a couple of months after the egg collection, based on the clinical situation. And there is no difference in success rates whether you perform a fresh embryo transfer or a frozen embryo transfer. And if you thaw the embryo, the success rates on surviving that thaw process is very good, and you can see it's nearly 100%. As I mentioned, if you were to undergo PGTA, it does take a few weeks for the results to come back. So by definition, it would be frozen embryo transfer. Okay. So once we've developed and created the embryos, the final stage is the embryo transfer. So the embryo transfer is very similar to a smear test, a cervical smear test. Essentially with a, you can see here with a clip instrument and with a very fine catheter, we essentially go through the cervix into the lining of the womb and simply inject the embryo. Sometimes we scan to see exactly where we want that to be as well. And then the procedure doesn't take more than 10-15 minutes really. You then do a pregnancy test approximately 2 weeks later, and if it's positive, we arrange a pregnancy scan a couple of weeks later, and if it's negative, then we have a team meeting and we go through your treatment cycle. And if you have embryos left in storage, then we'll concentrate on a frozen embryo transfer, so you don't necessarily have to go through that whole egg collection process. So that's IVF. IUI is another treatment option, and it's quite popular amongst many patient groups. IUI is an acronym that stands for intrauterine insemination. So as the name suggests, intrauterine, inside the womb, inseminate, essentially we inseminate the sperm. So we often we give medications, oral medications, from the beginning of your cycle, from day 2 to 6 of your cycle, and that helps to grow the follicle. And you do home ovulation testing from day 9, and once it turns positive, then you will perform the IUI. Now, if you don't ovulate, we monitor through ultrasound scan, and as long as there's a dominant follicle of sufficient size, then we can give you an injection, which we call a trigger injection, which will help the ovulation, and essentially we'll perform the IUI the next day. But IUI does rely on a couple of important factors. So one would be that we require the fallopian tubes to be nice and open and healthy and patent, because we want that sperm, which is released by the egg, to travel through the fallopian tube to meet the sperm in the first place. The second thing is that it does rely on a good semen analysis result. So if the morphology is very low, if the movement is very low, then the success rate is going to be lower. We also offer shared motherhood. So for same-sex female couples, one partner would donate their eggs, and who would undergo the egg collection procedure, would create embryos, and essentially would be the biological mother, and the partner would essentially have the embryo transfer, carry the pregnancy, and will therefore be the birth mother. In terms of donation, we have a very dedicated sperm and egg donation team and surrogacy team as well. And the benefit in working in a large company, because in the UK, is that we have our own sperm and egg banks. And you can see the list here of some of the sperm banks, which include the European Sperm Bank in Denmark, London Sperm Bank, Brighton, and California, for example. So we have partnership with these different sperm banks. With regards to egg donation, then Actually, Care Fertility is one of the leading egg donation programs in Europe with very good success rates. And you have a choice between doing either a frozen egg treatment or a fresh treatment cycle. So if it's a frozen egg cycle, they usually come in sets of 6 or a large set of 9 eggs. We also have our Spanish sister clinics, so we can obtain the eggs through them. By law, anyone who does donate their eggs have to be between 18 and 35 years of age. There are some exceptions to this. So, for example, if you have a known donor or sibling who's slightly older outside this range, through multidisciplinary meetings, that can be arranged as well. With regards to surrogacy, yes, Care Fertility has won the National Surrogacy Awards and has been voted Surrogacy Clinic of the Year. It can be quite complex, but essentially there are 2 types of surrogacy. You have a host surrogacy or you have a direct surrogacy. So in the host surrogacy, the baby is not related to the surrogate mother, and the intended mother or parental mother-to-be can donate her own eggs. Whereas in its direct surrogacy, the egg is from the surrogate mother and therefore is the biological mother. So here at Care, so it can be recognized that the IVF journey can be challenging at times, and we offer support along the way. So in terms of communication, we have recently created and developed a new app, which is called Salve, which is essentially a portal of communication. So it allows you to keep track and book all your appointments. As you can see, stay on top of your medications. You can sign the consent forms digitally. Payment is secure, and you can share your treatment plans with your partners. In terms of the IVF payment programs, there are different programs that we offer. There's IVF refund programs, there's IVF multi-cycle programs. So for example, instead of performing single IVF treatments, and let's say it doesn't work, you'd have to pay for another treatment cycle. And that's where the multi-cycle or the Care Pay program may be more suited to you. We have different, we have also a donor egg refund program, which can provide up to 100% refund of your IVF treatment. We do offer interest-free credits as well. T's and C's, of course, do apply. I'd advise you to read them because there may be a cancellation fee. So it's important just to read the T's and C's carefully. We're also offering a full fertility check offer, which does end at the end of the month. And essentially go through what I was describing earlier in terms of the pelvic ultrasound scan, the semen analysis, anti-Müllerian hormone blood test, as well as the initial consultation with one of our fertility specialists. As I mentioned, support is offered throughout each step of the way. We have different forums, as you can see. So there's a men's forum, there's egg donation forum, the general forum there as well. I like this quote: every patient and journey is unique. We can all be there to support one another's hopes and dreams, just like a real family. As I mentioned, support is throughout your whole journey. So we have a new general patient inquiries team. We have a care resource hub. We have care pals, who are essentially the point of contact. And though after the initial consultation, for example, they'll go through with you the next steps. We have different care forums. We have dedicated counselors throughout your journey and is available at any point. And of course, we have the social medias, the Instagrams, Facebooks, and YouTubes, tweets, and WhatsApp. So that's the end of the presentation. Thank you all for listening. I hope you gives an insight into the journey of IVF, what an IVF cycle entails, what are the different test investigations we use, why we use them, what are the different treatment options we have, how we individualize care, what are the different add-on options that we can consider, and of course, provided with the support all along the way. So if you'd like to arrange an initial consultation with myself or one of my colleagues, you can contact the General Inquiries team, which can be found on the website. Thank you again once again for listening, and I'm happy to go through any questions. So I'm just looking through them now. So we have a question on what are your thoughts on ERA tests? So yes, so ERA tests, so for those of you who don't know, essentially when we perform a frozen embryo transfer, the timing of progesterone is important, and there was a very large study which was performed by Professor Simon Fishel, which looked into the timing. So there is a window of opportunity in terms of when is the best time to take the progesterone support. And so in patients who have recurrent implantation failure in particular, it's more relevant to that group. And so, yes, we have seen positive outcomes with that. We do offer the ERA test. I would say at the same time, you can perform an ERA ALICE and EMMA test. So essentially, it's a mock embryo transfer cycle. So you're prepped up as if you're about to have an embryo transfer, but instead of having the embryo transferred, we take a biopsy of the lining of the womb. And that's where you can get the ERA, but at the same time, you can take ALICE and EMMA test. And that can check the infection, inflammation, and whether we need to give antibiotics and or probiotics. So I think they all work together well. Yes, we have seen some good outcomes, positive outcomes following ERA test, but also ALICE and EMMA. Just going through some of the other questions. Does your fertility change after you go through the IVF treatment? Good question. The short answer to that is no. The medications that we give, it's for a short duration, and this is a relatively short dose, and it doesn't affect your ovarian reserve, your egg reserve. So it doesn't change in that sense. Just going through some of the other questions. There's a question which says, can you go straight into IVF and skip the IUI treatment if you want a higher chance to conceive? The answer is yes, you can. In terms of, if we look at the success rates, of course it is individualized, and we'll go through individually what the chance of success will be. But generally speaking, for IUI, the success rate is approximately 10 to 15% per IUI, and IVF, generally speaking, is approximately, depending on the clinical situation, of course, approximately 1 in 3 would be the average. So you can just not do IUI, but go straight to IVF. Because the reason why it's higher is because you've already created embryos, and we only store the ones which have the potential to become a baby. Whereas in IUI, as I described earlier, it does depend on a few factors. It does depend that the egg is released, it does travel through the fallopian tube, it does meet the sperm, the fertilization does occur, and a good quality embryo does develop, and it does implant. So there's lots of steps on the way which can affect that success. So that's why, generally speaking, IVF is more successful. So another question, is IVF possible for males with low sperm count and high testosterone? So it's a good question. It depends on how high the testosterone is, and it depends on other factors involved. So there are other hormones which are important that we need to check. So we do a full workup, which does include testosterone, other hormones, FSH, LH, because we need to establish, okay, is there a higher function cause here? But if it's the low sperm count in itself, yes, you can perform IVF, but IVF, we would probably recommend ICSI, like I was describing earlier. So I'm just going through these questions and trying to see the theme here. There's a question about does a single female of 39 years old should go for egg freezing or IUI or IVF? Good question. Again, it does, generally speaking, after 38, we don't generally advise egg freezing. We would recommend development of embryos, and that's because as age increases, the quality of eggs do decline. So if you look at the whole population, fertility does decline from 35, it does plateau, and then from 39 to 40, you do see a significant decline there. So creating embryos would be more preferable because you have that embryo, and still it's not guaranteed that it will definitely work as well. Okay. That's a question. If you have a low AMH, is there any way of improving naturally prior to IVF? Unfortunately, not. AMH is because you were born with a fixed amount of eggs, tens of thousands at birth, and then microscopic. And what AMH, like I mentioned, is produced by the follicles. So you can't produce, essentially, the follicles. So unfortunately, it will naturally decline, and there's nothing that we can do to help increase that AMH, that egg reserve. This is very nice message. Dr. Robati and his team at Tunbridge Wells are amazing. I was nearly 39. Went through solo IVF. I was blessed to be lucky to have a success story on my very first attempt. I know how I won't give the name, but thank you, Dr. Robati. You're very welcome. It's very nice to see that, and I think it just highlights what we do and why, and that's why I love what I do, and that's why if I could help a couple or single parent to conceive, it's a absolute joy. There's a question again, how likely is it for the embryo to stick first time for a healthy 19 to 20-year-old in IVF? Again, it does depend on the history. So it does depend on that, and we won't know until we do the test investigations, both for yourself, but also for the partner as well. And we put everything into context. If I were just to say just by what's the embryo's chance of success in a 19-20-year-old, if all the parameters are normal, AMH, antral follicle counts, semen analysis, no significant medical history, then the chances are very good. If we look at the live birth rate, it's probably going to be a good 40%. And that's live birth rate, so that's a chance of baby. Clinical pregnancy rates will be higher, but unfortunately not every pregnancy will result in baby. Unfortunately, we do have biochemical pregnancies, miscarriages, and whatnot. But I'd say at 19-20, given those parameters, it would be a good 40% at least. Right. So I think there are a few other questions which I think are a little bit, without knowing the full picture, it's hard to know exactly what the success rates would be, because every case is individualized, and that's why we do a thorough test investigations, go through the history to determine more information. So there's a question about whether ICSI is available for the patient to request or determined by the doctor, and what is the success rate of IVF versus ICSI. Yes, good question. There's always going to be a clinical reason for performing ICSI. Like I mentioned, there's some evidence to suggest if one or more of the parameters is on the lower side, together, it depends on the history, because if you've been trying to conceive for 2 years, for example, and you haven't fallen pregnant, then ICSI can help improve outcomes. When we perform ICSI, it does depend on the level of the parameters. How low are the parameters that we're using ICSI in the first place? So it's hard to put all that information together, and there aren't enough robust studies which take all of these confounding factors into account to determine what the difference between the success rates of IVF or ICSI. But generally speaking, as I mentioned, if one or more low parameters are on the low side, together with the history, then ICSI would be more favorable in terms of fertilization rate. So what are the reasons one would opt for IUI over IVF? So a few factors there. So sometimes IVF may be seen as maybe a little bit more invasive, if you like, with the injections and the daily injections. IUI, as I mentioned, is just essentially giving oral medications. And as long as the fallopian tubes are nice and patent with normal semen analysis, then yes, you can opt for IUI. The other important factor, of course, is cost. IVF is more costly than IUI, but the success rates are better. So it's weighing that balance to see whether you would go for IUI or IVF. And what I would say about the IUI is that if you look at the studies, if it hasn't worked by 2 or 3 times the IUI, then the likelihood, the probability is that it won't work. And then you would go to IVF. So then there's always that decision to make. Do you therefore go straight to IVF in the first place? There's a question about if sperm motility is overall very low, is there any effect on chance of a healthy baby? No is the answer to that. Through the literature, there's no evidence to suggest that it will affect the health of the baby. Right, so I think that's all of the questions there. There are quite a lot. If there are any that I have missed, then I'll make sure that I'll answer them. But Sam, yes, I think we can probably wrap it up there.
Okay, well, thank you everybody for joining us tonight. Our inquiries team are available from 8 a.m. tomorrow on 0800 564 2270 or at inquiriesteam@carefertility.com. Once again, they're available from 8 a.m. tomorrow on 0800 564 2270 or inquiriesteam@carefertility.com. Thank you very much.
Thank you, guys.